So on this slide, I talk about the voltage-dependent calcium channels. They're found in cells that often undergo depolarization. It allows the calcium to flow from the extracellular space into the intracellular space. And the calcium not only is responsible for muscle contraction, but in other cells it can excite neurons, it can upregulate gene expression, so you can turn on certain genes to produce certain protein elements. It can release hormones and other neurotransmitters. So this pathway through cyclic AMP, releasing more calcium in a cell, is multimodal. But in the heart muscle, its very important effect here is that it's causing greater force of contraction of the heart. And so I just reviewed for you, in case you've forgotten on these next couple of slides, how muscle contraction occurs with the help of calcium, unlocking the troponin cross bridges. In case you've forgotten how it works, I've reviewed it for you here. I expect you to have, respectable knowledge of that part of exercise phys. Come back in 15 minutes and we'll look at calcium channel blockers. And just as a prelude into it, if I can block calcium from entering the muscle cell, then I can decrease the force of contraction, can I not? So it's going to be pretty obvious how calcium channel blockers work. And so their mechanism of action is pretty straightforward. It prevents calcium ions needed for muscle contraction from entering smooth and cardiac muscle cells. So the action now is going to lower both systolic and diastolic pressure and also help to reduce angina. Some calcium channel blockers, such as procardia or nifedipine, also slow the electrical impulses that run through the heart. Thus, they're also used as anti-arrhythmic agents as well. Where people have arrhythmias, they sometimes will give them calcium channel blockers as well. So the clinical applications then are, first of all, in high blood pressure, because they block the voltage-gated calcium channels in muscle cells of the heart and blood vessels. So this is going to prevent calcium levels from increasing as much in the cells when stimulated, leading to less muscle contraction. So the myocardial muscle is going to contract with less force. That's going to bring down the systolic pressure. In blood vessels, there's a decrease in calcium results in less contraction of the vascular smooth muscle, which will allow more vasodilation. That brings down the diastolic pressure. So vasodilation decreases total peripheral resistance and reduces cardiac contractility, and so you basically get a blood pressure lowering effect. In angina, the vasodilation effect lowers the afterload on the heart. So in other words, if I dilate the arterial system, then when the heart pumps, there's less blood pressure flowing back towards the heart. So that's known as the afterload. It's easier on after the heart can pump and there's less resistance flowing back. There are drugs like nitroglycerin that do the opposite. They dilate the veins, so there's less preloading and there's less blood flowing back into the heart, so the heart doesn't have to work as hard because you get dilation of the venous system. Less blood flows into the heart chambers in the first place, so the preload force on the heart is less. But with calcium channel blockers, it decreases the afterload on the heart, so there's less oxygen demand, and that will decrease symptoms of angina, of course. Sometimes this effect decreases blood pressure, but as the blood pressure drops, the baroreceptors of the nervous system notice that the blood pressure is dropping, so in response, they secrete more catecholamines to bring the blood pressure back up. So it's not uncommon to see somebody who's on a calcium channel blocker also on a beta blocker to block now the effects of the baroreceptor response. So you start to see one drug needs to the requirement for the next drug, and then you're going to see this sort of continues. So it's not uncommon to see a high blood pressure patient who's on more than one antihypertensive medication. So you're going, how come this person's on a diuretic, on a calcium channel blocker, they're on a beta blocker, and if they're a diabetic, they might also be on an ACE inhibitor. You're going, how come they gave them 4 different antihypertensive drugs? It's bewildering unless you understand some of the physiology. The calcium channel blockers would not be used in cardiomyopathies. If the heart muscle function is already weak, the last thing you want to do is deprive it of calcium so the heart muscle can contract. So it would be contraindicated in certain cardiomyopathies where the heart muscle is already weak. Some calcium channel blockers slow the conduction of electrical activity within the heart, resulting in negative chronotropic effect. And so if the person already is at risk for heart block, and you slow the electrical conduction even more, that would give them an adverse cardiac event. So they would be off the list of people that would use it. Whereas if someone has atrial fibrillation, the negative chronotropic effect by calcium channel blockers make them ideal agents for atrial flutter and atrial fibrillation. So in addition to their use as antihypertensive drugs, if the person happens to have atrial flutter or fibrillation, calcium channel blockers are often used for that purpose, to decrease the electrical excitability of the heart cells from that standpoint. So they're not just antihypertensives. So they're used for hypertension, angina, and arrhythmias for obvious reasons. Side effects, fatigue, but notice this one. Patient comes in, they've got abnormal swelling of their ankles, of their feet, maybe of the abdomen, just out of nowhere. You're going, swelling of the ankles, did you sprain your ankle? Is this congestive heart failure? Is it pitting edema? Have you been on any new medications lately? Yes, I'm on nifedipine. Oh, it could be a side effect to the calcium channel blocker. These are less common side effects. Notice tingling and numbness of the hands and feet is one, but it's not that common. I wouldn't hold you responsible for that one. Some other rare side effects. Notice headache, chest pain, but these are really rare, so no one can remember this whole list. I've included in your notes. I don't expect you to remember these ones unless I put an asterisk next to it and really try to highlight it in some way. You'll notice that the calcium channel blocker drugs, these are sort of the names, the proprietary names. These are the generic names. Notice they often end in MIL or pene, like nifedipine. You see that one? Verapamil, very common. So just sort of tips you off. If you see pene or mil at the end, often you're dealing with a calcium channel blocker. The best thing is just enter it into a Google search. It'll tell, calcium channel blocker. Your brain says, oh, I know what that's doing. I understand why it was prescribed. I need to make sure I don't do something that's going to counter that effect. Just something you might want to know that I think is interesting in sort of integrative cancer therapy is that some calcium channel blockers like nifedipine and verapamil also inhibit what's known as the multidrug resistant pump. So sometimes when you're giving a patient chemotherapy to try to kill a cancer cell, the cancer cell mutates and becomes very intelligent, starts to upregulate a pump that pumps the chemotherapy back out into the extracellular space to protect itself. And one of the pumps that it's using often is as a calcium channel pump. So what these efflux pumps, these glycoprotein pumps, there's a gene known as the multidrug resistant gene that gets upregulated in cancer cells when they try to defend themselves. What's interesting is that some of these calcium channel blockers can actually inhibit the action of these pumps to keep the chemotherapy in the cell to make it more effective at killing the cancer cell. So sometimes these calcium channel blockers are used in what's known as off-label use applications to help increase the efficacy of chemotherapy when you see that the cancer cell is overexpressing the multidrug resistant gene. But you might want to also know this, that certain natural flavonoids do the same thing. They can inhibit that glycoprotein pump that pumps the chemotherapy drugs back out. Flavonoids like curcumin from the spice turmeric, flavonoids, the isoflavone genistein from soybeans, and also quercetin, a flavonoid found in apples and onions. But you have to give these things at therapeutic levels, highly concentrated supplement dosages, to downregulate the effect of the multidrug resistant gene. So these are also very good flavonoid supplements to give to the patient on certain chemotherapies if you see that the cell is mutating and increasing the multidrug resistant gene.